So next we're going to talk about distant direct phoneoscopy, which is using our smartphones to mimic the distant direct ophthalmoscopy technique, which is one of the most powerful, simple tools in our ophthalmic examination arsenal. A very quick way of screening for corneal lens, retinal disease, as well as neurological function by looking at the way the pupils respond to light. So a very powerful way to quickly give an overview of the ophthalmic health of our patients. But using our phones, we can do that and record it as well. So to perform distant direct ophthalmoscopy using our ophthalmoscopes, we set it on 0 and we hold it close to our eye and about arm's length from our patient, obtain the fundic reflex, and then by moving the light in certain ways, we can assess very specific things. So, for example, the first thing we'll do is use it as a pupilometer to measure pupil size, symmetry, shape, and response to light. Then we will do that for each eye. Then for each pupil, we will look at the tapetum reflection and see whether it is symmetrical with the other. Is it as more reflective, which might suggest retinal degeneration, or less reflective, which might reflect intraocular opacities. And after that technique, we will hopefully will proceed to looking specifically for opacities in the visual axis, which is the corridor of light in the primary gaze position of your patient. Once we've assessed the visual axis, we'll then look outside the visual axis for equatorial lens changes, anterior visual changes, which are a very important place to look for pathology. And then finally, any opacities we found in or outside the visual axis, we will try and localize by moving ourselves around to change the position of those opacities as we look at the fundic reflex and try and use that to calculate whereabouts they are in the visual axis. It doesn't have to be an ophthalmoscope. It can be any light source, as long as it's held as close as possible to our lights. It can be a pen torch next to our eye. It can be the camera light on our phone held by our eye, or for this talk particularly, and practically most of my working life, we use the phone camera with the light turned on continuously, which allows us both to perform this technique and record it, and also to zoom in, which we can't do with our own eyes. This is how we would use it as a pupilometer. So this is a case which is referred to us for sudden onset blindness. Another one, probable cataracts as the suggested cause. And what we're doing is we are looking from a distance, and we're trying to have the cone of light large enough to cover both pupils, and therefore give us a fundic reflection from both pupils. So we look here, the bottom right hand picture, we can see the fundic reflection in the right eye and the left eye are different. We've got a yellow and a white fundic reflection in the left eye. We can see a small black dot in it. So again, so the right eye, we got this whitish appearance, the fundic reflection, and the left eye, this yellowish appearance. Now, if we look at the right eye, by changing the angle very slightly, it can change from a greyish white fundic reflection to a bright peach coloured fundic reflection, which automatically starts to ring alarm bells that that's not a problem with the lens. Expect the lens, any effect the lens has on opacity, reduction of the tapetum reflection to be consistent. You can look closely at this image. We can see lots of other things and guess what's going on. We've got big dilated pupils, which are non-responsive to light, which would be unusual for cataracts. Cataracts don't blind horses because the light can't get through. It's just the light can't get through in a focused manner. Horses with cataracts should have a brisk, normal PLR. So we've got big dilated pupils, non-responsive to light. We can see the granular iridica in both pictures actually are very small and shriveled, and the irises are almost black in colour. So those two signs, shriveled granular iridica and a dark iris, are very typical of chronic uveitis. And there are cataracts, there are cataractus changes here, but the reason for this horse being blind was due to bilateral. we can use our cameras to assess changes in the visual axis. So we're looking straight at this horse, so looking naturally at its primary gaze position or near to it, and we are looking for any changes in it. And we can see this slug trail going across the front of the eye. Now, this isn't a true opacity. This is what's called a refractive change. It is a linear keratopathy lesion caused by a split in Descemet's membrane, so it still remains transparent. But it is a difference in refraction, which allows us to see it. And we can tell the difference in refractive change, such as nuclear sclerosis or linear keratopathy, compared to cataract, which actually blocks the light as opposed to bending it a slightly different way by changing the intensity of our light. So if we change the intensity of our light on our phoneoscopes, or we decrease or increase the exposure on our camera, we can make these lesions appear or disappear, which helps us to differentiate them from true opacities. We can use other parts of the visual axis we can look at. This is another example of how we can use this to look at corneal lesions. This is a horse who's had a keratectomy. So the keratectomy site's here and it's fluorescent positive. There's no coaxial light. So we have a oblique light coming in, bouncing off the cornea and giving us beautiful reflection. So we can see reflection of our cells in the normal cornea. So it tells us that cornea is reflective and therefore likely to be healthy. But over the keratectomy lesion, there is no retained tear film and no reflection. We turn the light on, we can now see the pupil. It's nice and dilated. You can see small granular iridica. We can then look carefully because we're suspicious that might be abnormal. In this case, it wasn't. It was normal variation. We can also see that this part of the keratectomy site is still transparent, which is encouraging because we don't want any infiltration in this site. At the bottom, you can see some blood vessels going in as well. So we can actually start to see a lot more information about the transparency of the cornea when we turn the light on. Another example of a corneal lesion. This is a horse with corneal edema. In the top picture, there's no coaxial light. We can see reflected light on the surface of the cornea. We can just about make out the pupil. We can see this large area of corneal edema and maybe some greying over here. When we turn the light on, we can suddenly see our pupil. We can see small granular iridica again, so we need to look at those carefully because if those are shriveled, that might suggest chronic uveitis. We've got a dark iris, which points us towards chronic uveitis. And we can also see that over the densest part of edema, we've got these little tiny grey dots. And these grey dots are precipitates of pus on the inside of the cornea, keratic precipitates, one of the cardinal signs of chronic uveitis. So now we've got a horse which has got a large area of corneal edema and chronic cytochronic uveitis, which means we now start worrying about other secondary changes such as glaucoma in this eye. We can also look for opacities outside the visual axis. So we're now looking right around the nose of this horse, so looking back, and we're trying to look towards the edge of the anterior vitreous. And these strands you can see here will be normal, actually, in this case, but vitreal degeneration in the anterior part of this peripheral anterior posterior segment of the eye. We can also see some vitreal rest, iris rest caused by as a sign of uveitis, and incidentally a little bit of vitreal prolapse. And finally, before we leave, the most useful of our techniques, I think, is distant direct ophthalmoscopy or phoneoscopy. Just a quick reminder that your camera is very useful for attaching to your microscope and taking pictures of cytology, to send off for records or to send off for opinion. This beautiful picture here is a picture of tear ferning, where we take a horse's tears using a pipette. We put that onto a slide. We let that dry out at room temperature. As the salt crystals crystallize, they crystallize along the organized mucin molecules in the tear film. And by looking at this pattern, we can interpret, at least make some comment on the quality of the mucins in these horses.